This recording will cover encephalitis. Encephalitis is an inflammation and infection of the brain tissue and often the surrounding meninges. A viral agent most often causes the disease, but it can be caused by other things such as bacteria and fungi. The virus travels along the central nervous system via the bloodstream, along peripheral or cranial nerves, or in the meninges. Viral encephalitis can be life-threatening. After the virus invades brain tissue, it begins to reproduce, causing an inflammatory response. Unlike in meningitis, this response does not cause exudate formation. It causes degeneration of the neurons of the cortex. Demyelination of axons occurs in the involved area because the white matter is destroyed. This destruction leads to hemorrhage, edema, necrosis, and the development of hollow cavities, small lacunae, within the cerebral hemispheres. Widespread edema can cause compression of blood vessels, leading to a further increase in intracranial pressure. Death may occur from herniation and increased intracranial pressure. Viral infections that can cause encephalitis include arboviruses, which are transmitted to humans through the bite of an infected mosquito or tick, West Nile virus, which is spread through mosquitoes. Also, herpes simplex virus can cause encephalitis. Patients with the disease often have a history of cold sores. Amoebic meningoencephalitis is caused by amoeba, both found in warm freshwater areas and the two kinds rather, are both found in warm freshwater areas and can enter the nasal mucosa of people swimming in ponds or lake. The typical patient with encephalitis has high fever and reports nausea, vomiting, and a stiff neck. Other signs and symptoms can include change in mental status, such as agitation, motor dysfunction, such as dysphagia, focal neurologic deficits, or specific neurologic deficits, photophobia or phonophobia, fatigue, symptoms of increased intracranial pressure, joint pain, headache, and vertigo. Remember, decreased level of consciousness is the first sign of increased intracranial pressure. Assess level of consciousness using the Glasgow Coma Scale or other approved tool. Mental status changes are more extensive in a patient with encephalitis than with meningitis. Changes include acute confusion, irritability, and personality or behavior changes. Signs of meningeal irritation include the presence of neck or nuchal rigidity and motor changes that vary from mild weakness to hemiplegia. The patient may have muscle tremors, spasticity, ataxic gait, myoclonic jerks, and increased deep tendon reflexes. Seizure activity is common. Observe for cranial nerve involvement, such as ocular paralysis, facial weakness, and nystagmus. In severe cases of encephalitis, the patient may have increased ICP resulting from cerebral edema, hemorrhage, or necrosis of the brain. If the patient is nonverbal or comatose at baseline, monitoring vital signs and pupils becomes essential for detecting worsening neurologic status and increased ICP. Changes in vital signs that require notification to the healthcare provider are a widened pulse pressure, new bradycardia, and irregular respiratory effort. Pupils that become increasingly dilated and less responsive to light are also communicated urgently. Left untreated, increased ICP leads to herniation of brain tissue and possible death. Lumbar puncture is done to analyze the cerebrospinal fluid for the specific offending organism. An EEG is done to evaluate brain wave activity to detect seizures. Brain imaging in the form of a CT scan with or without contrast is performed to evaluate elevated intracranial pressure or obstructive hydrocephalus. Regarding interventions, we want to teach people that live in areas where West Nile viruses are common ways to prevent getting bit by mosquitoes that may carry the viral infection. There is no curative treatment for West Nile viral encephalitis. We want to remind individuals not to swim in lakes or ponds that are not designated for swimming to prevent amoebic encephalitis. In regards to West Nile virus, we want to limit time outside between dusk and dawn where mosquitoes are out. Wear protective clothing, long sleeves and pants, use insect repellent. Remove areas of standing water from flower pots, trash cans, and rain gutters. Check windows and door screens for holes that need repaired, and keep hot tubs and pools clean and properly chlorinated. Acyclovir can be used for the treatment of herpes encephalitis. Drug therapy is most effective if begun early. Nursing interventions for encephalitis are similar to those for meningitis with the exception of drug therapy. Supportive nursing care and prompt recognition and treatment of increased ICP are essential for components of management. Maintain a patent airway to prevent the development of atelectasis or pneumonia, which can lead to further brain hypoxia. Be sure to provide supportive care for the patient who is immobile. Delegate and supervise UAP to turn, cough, and deep breathe at least every 2 hours. Perform deep tracheal suctioning even in the presence of increased ICP if respiratory status is compromised. Assess vital signs and neurologic signs every 2 hours or more frequently if clinically indicated. Elevate the head of the bed 30 to 45 degrees unless contraindicated, such as after a lumbar puncture or if the patient is experiencing severe hypotension. Keep the patient's room dark and quiet to promote comfort and decrease agitation. Provide support for the patient and family. And patients with encephalitis and permanent neurologic deficits are usually discharged to a rehabilitation center or a long-term care facility. Those with minimal neurologic problems are discharged to the home setting.